I have high noon. So I hope everybody brought their lunch, and we're going to start the meeting. Dr. Burke-Harris and Dr. Pond, it's all yours.
Thank you so much, Bobby. And I want to welcome everyone to another meeting of the Community Vaccine Advisory Committee. As you all know, I'm Dr. Nadine Burke-Harris, California Surgeon General and co-chair of this committee. First, I want to say thank you to everyone for accommodating a last-minute change to the timing of the meeting. We certainly apologize, and we're grateful for your flexibility and for the fact that so many committee members were able to make this new time on Friday afternoon. So very, very grateful. And I'll go ahead and turn it over to Bobby just to review our meeting processes, and then we can just dive right in, considering today we have a 2-hour meeting instead of a 3-hour meeting like we have in the past. Go ahead, Bobby.
Great. Thank you, everyone, and welcome to the meeting. I just wanted to remind everybody about our meeting process. I think everyone's very familiar with the fact that we love for you to keep your cameras on so that we can see you and sort of pretend that we're in person together. Don't forget to use the hand raise icon, which I think everyone is very familiar with by now. We welcome our 2 ASL interpreters, Mona and Judith, as well as we have closed captioning as well for our members and for the public. The public is in a listen-only mode in 3 modes: a public telephone line in English, one in Spanish, and also on our YouTube live stream watching the proceedings. If any of the CVAC members have any technical difficulties, if you can just put your technical question in the chat, we'll see if we can help you find your way to happiness with your technology on this call. So thank you very much for that. Dr. Burke-Harris, would you like me to go on and review the public comment?
Yes, please. Thank you, Bobby.
Great. So we've received quite a bit of public comment from the last meeting. Just as a reminder for the members as well as for the public, we closed down the public comment starting at ending at 5 o'clock on the Monday before the Wednesday meeting. And because we didn't know that we weren't having the Wednesday meeting this week, we did close it down on that schedule. Any other public comment that's received after that time will be included in the next round of public comment. This just gave our members more time to read and think about the public comment that was submitted. We received 59 pages of public comment, including links to an additional 16 pages. 216 individuals and organizations provided very thoughtful and in some cases very moving and passionate comments. I hope everyone had a chance to read them. Let me summarize them quickly for you. 3 people asked that we simplify the whole vaccination system, announcing where people can get vaccines, making public announcements, and making it much more easy to access vaccine appointments and schedules. 12 individuals representing flight attendants requested that the Flight Attendant Association be allowed to join as a member of the Community Vaccine Advisory Committee to represent the transportation industry. 6 organizations asked that we use existing local childcare collaboratives to reach and vaccinate childcare workers throughout the state, with the 10% set aside for education and childcare sectors. One person urged us to use an age-based approach for all vaccinations. Another individual wrote asking us not to use an age-based approach for vaccinations. And one organization wrote and asked us to use zip codes with the highest incidence of COVID disease as the only way to target vaccination prioritization. 6 individuals with high-risk conditions, disabilities, and people on IHSS acknowledge that they cannot wait until March 15th to get their vaccinations, and they'd like to get them sooner. Another individual asked that California use the same list of underlying medical conditions and disabilities as other states. Another individual asked that we publicize what kind of verification or documentation individuals with high-risk medical conditions and disabilities need to produce so that they can get their vaccines. We had a number of people asking that the following underlying medical conditions and disabilities be added to the list of those groups that will be able to receive their vaccines starting March 15th. That included rare lung disease, pneumonia, 12 people advocating for cystic fibrosis, 2 advocating for all types of cancer, allergies to medications due to immune system dysfunction, early onset of Alzheimer's disease, B-cell antibody deficiency, bone marrow transplant, breast cancer, Crohn's disease, multiple sclerosis, a number of people urging us to add type 1 diabetes to the list, people living with AIDS and HIV, cerebral palsy, immune suppressed individuals due to disease modifying therapy, chronic respiratory disease, and serious mental illness, including schizophrenia. We had a very passionate letter from a 16-year-old asking that his mother be vaccinated because she is entering the hospital for surgery. We had a plea for sending more vaccines to Imperial County, which has had high infection rates and has thousands of agricultural workers. We had 78 organizations writing to ask us to prioritize hire people and people experiencing homelessness and organizations serving them. We had 64 organizations and individuals asking us to prioritize people living in congregate settings, especially prisons, county jails, and immigrant detention facilities. We had 30 organizations and individuals writing to tell the California Department of Corrections to reduce incarceration rates in state prisons to below 50% capacity and to prioritize vaccinations for staff and inmates. We had 2 individuals write to ask us to clarify which teachers should get vaccinated when the education sector gets vaccinated. Those teachers that are going back to teach in person in the classroom or already are teaching in person, or those who only work online from home. The following sectors and workers were asked to get higher on the prioritization list. All essential workers based on the governor's list, the Boys and Girls Clubs, nannies and family care providers, foster parents, public transit workers, airline flight attendants. We had 15 letters from hardware store and home improvement store employees, automotive retailers and their employees, cosmetologists, hairstylists, personal services providers, letter carriers, workers in banks, construction, veterinarians, and their staff. And that summarizes the public comment that was received that I know all of the members of CVAC have reviewed in detail. Thank you.
Thank you so much, Bobby, for that summary of our public comment. And now as we dive into the meeting, I'd like to start with a quick reflection on how far we've come through this process. I know that last week we certainly reached a very sad milestone as we reached 500,000 deaths from COVID in the United States and 50,000 here in California. And I just want to reflect because I feel like so many people that I know that I have come into contact with, I've just been hearing over and over again that people have been feeling, you know, so tired, so exhausted, just kind of feeling like we were in a really challenging place. And as we look ahead and see how far we've come and where we are right now, I think that when we look at the month of March, we have seen a couple of things that are also show real exciting signs of promise and progress. So of course we had the FDA emergency use authorization for another vaccine, the Johnson Johnson vaccine. That is a one-shot vaccine, which feels really exciting. And we heard the announcement from President Biden that he supported a partnership between Merck and Johnson Johnson to produce even more of the vaccine, and that he anticipates that we will have enough supply for every adult in the United States by the end of May. In addition, yesterday we heard Governor Newsom make the very exciting announcement about our California's plan to address equity in our vaccine distribution strategy by appropriately allocating 40% of our vaccine doses to the communities in the lowest HPI quartile, which are the communities that experience roughly 40% of morbidity and mortality from COVID-19. And so we see that in California, we have looked at the data about equity in our allocation, and we have really made an intentional effort as soon as we have, moved through doing the important work of vaccinating our vaccinators and shoring up our public health system, to move importantly to addressing and redressing, right, the ways in which prioritizing our healthcare workers has led to a skew in the way that our populations have been served. And so that feels incredibly important. And as we move forward in the process of transitioning, what we see that is also going to happen in this month of March is a transition to our third-party administrator. We wanted to spend time in this meeting taking a deeper dive with you into the work of the TPA, how we plan to do our vaccine distribution plan. And we want to invite you to share your thinking about how we can best implement and even improve on our current plan. So you will hear today, after an update from Dr. Pan on how we're doing with vaccines, you will hear from Marta Green with GovOps, from Dr. Kimberly Good with Blue Shield of California, as well as Peter Long at Blue Shield, about the plans for implementation from our third-party administrator, as well as Andy Patterson from the California Primary Care Association about the partnership and the role with our community clinics. You'll also hear an update from our Department of Public Health on that Johnson Johnson vaccine, so a little bit more detail there. And then finally, an exciting update about My Turn volunteers. And so with that, I want to turn it over to Dr. Pan, my co-chair and partner in crime to share our latest exciting update on where we stand as we begin to see that light at the end of the tunnel getting brighter and brighter.
Great, thank you so much, Nadine, and good afternoon, everyone. And I just want to, again, appreciate all of you and your partnership and flexibility. We really wanted to have important and useful and up-to-date information for you. And I think, now that you've seen sort of the announcements over the last 24 to 48 hours, I hope it makes more sense that we wanted to be able to share this really incredible progress. I think I just want to reflect as well, as Dr. Burke-Harris did. I think, we did have a sobering moment very recently, and there are a lot of anniversaries, that continue to evolve. And I think we're coming up on the anniversary of the first stay-at-home order, which was in mid-March of last year. And I think, I do know that can be triggering for some people, just about what a long, hard year it has been. But, what is really exciting is literally today myself too, I just really, the light at that end of tunnel is really getting brighter. And and I'm really excited to share some progress with you on all of these fronts. So with that, I'll start with my slides. So this is kind of, our epidemic curve, as we call it, and this is all the progress we've made as far as decreasing cases. So the blue line is the decreases in cases. So you see a very steep decrease. And I think this is also to help you all see as far as the red line, and that is the deaths. So we still continue to hear every day about deaths, but there is a large time lag. So really the peak is still, much further back in late December during that surge. It always is a little bit, it's not only a little bit behind the peak in cases, but the reporting takes much longer. Sometimes we hear about these final death data, weeks later. So while we're still hearing that, we really have gotten past that peak and are making a lot of progress again. And then the orange line is hospitalizations. We continue to see those steep decreases in hospitalizations and in new admissions, which we're watching very closely. And then the black line is ICU. So all of those things are showing really encouraging trends, as is something else that's not on this slide, but test positivity, which is another parameter we look at to really monitor the levels of disease transmission in our community. And all of those have a lot of progress. We are, of course, very warily watching for variants and ramping up our whole genome sequencing to make sure we're detecting those and watching those and modeling those very closely. But everything that we're seeing now is very encouraging. Next slide, please. And then this is like some incredible progress I'm really excited to share. And you can just see, really visually how much we've ramped up. So, early on in the vaccine distribution and where we are now. And we just hit a hallmark. This slide is already out of date. We have hit 10 million doses in California, which is just so exciting. And 3 million people are fully vaccinated. So we've just really come such a long way and really exciting and really on our way towards immunity across California. Some other things around that are in our over 65 age range, we have covered over 23% of people that are fully vaccinated. And that's about 1.5 million elderly over 65 fully vaccinated. And as you can see from this chart, our pace of vaccinations has dramatically increased. Recently, it's been over 200,000 doses per day. And weekly, we've ramped up to, most recently, it's over 1.6 million doses per week over the past week. So it's just continued to increase. That little dip in green was when there was the storms and the delay in delivery of some shipments, and that's why there was a dip. But as you can see, there's been a great catch this week. So huge progress. But what we have highlighted and what Governor Newsom highlighted yesterday and what we are continuing to be dedicated to work with all of you on is equity. And we have a long way to go there. We have work to do. Before we talk more about that, I wanted to just review, next slide. So I know we continue to have a lot of questions and know that because there have been changes, just wanted to re-outline again kind of where we are on who's eligible and how we're defining those. So early on, what we called phase 1A was our healthcare workers and our long-term care residents and workers in our skilled nursing facilities. Phase 1B was when we opened up to people 65 years of age and older, and then also will be effective, actually is effective now, sorry, all of these sectors here, these top 3 priority sectors, which are agricultural and food, education and childcare, and emergency services. We have information on our website that kind of clarifies and has some footnotes on these sectors. They generally point to what are our essential infrastructure workers that are on the COVID-19 website. So we have details on that, and actually we're about to update and clarify some of those guidelines as well. So stay tuned for that. I think probably in the next few days as well, we'll be just sort of updating some of the clarity on that, because I know there are ongoing questions and some differing interpretations. So we're trying to be responsive to a lot of the questions that keep coming on those areas. And then the next slide, please. And then beginning March 15th, healthcare providers can use their clinical judgment to vaccinate people who are deemed to be at the very highest risk to get very sick from COVID-19 because of several different health conditions. And this is the list here. You can see this is it's based on the CDC list of conditions that are put people at higher risk for severe COVID-19 disease. Some of it was, the criteria was clarified or narrowed because it was a very large number of people. until we worked closely with our drafting guidelines work group to clarify and define that sublist a little bit further. And then also there's that list of medical conditions. And then if, as a result of developmental or other severe high-risk disability, one or more of the following applies. So if the individual is likely to develop severe life-threatening illness or death from COVID-19 infection, or acquiring COVID-19 would limit the individual's ability to receive ongoing care or services vital to their well-being and survival. And providing adequate and timely COVID care would be particularly challenging as a result of the individual's disability. And I think a shout out for a moment here too of, again, great collaborative work with a lot of you on this committee and other stakeholders. And I did hear that another state has adopted a very similar criteria for this, which is always encouraging. Later today, our drafting guidelines work group is also going to be meeting once again to just see if there's any last, we just heard again in public comments, there have been ongoing requests to reconsider other medical conditions and or to further clarify or define some of these criteria. So they're meeting again this afternoon, and we may have some updates after that. But just wanted to clarify, this list is here as far as and becomes eligible March 15th. A lot of you have had questions as well about implementation of this, which we know is a challenge and one of the ongoing challenges that we're all here to talk about as well. We have an implementation work group that's also comprised of many of you on this committee as well, that has been meeting around this and really working on how do we best implement verification and eligibility. We're always trying to balance, upholding these criteria for priority of people who really need this vaccine the most and can stand to benefit the most, and sort of, trying to balance not having barriers to people or to the operational aspects of getting vaccine into people. So that is something that is ongoing. So before March 15th, we will have more updates on from the state perspective and level and what we're working with the providers and the TPA on how that eligibility will be verified and some of the implementation aspects of that. But we know that's an ongoing question and challenge that we're working on, and we'll continue to update all of you and the public as that evolves. Next slide. And then actually the last thing I'll say about that last topic is after that, we are likely going to be moving next to the age-based framework. But again, ongoing discussions will always be evolving. And that list also says as ongoing data and science evolves, always working to make sure we're staying as up to date as possible. So to shift gears for a moment too, I think again, the big exciting announcement that has been made over the last day is that we are really, not only are we committed to equity as one of our important principles, how are we going to make ourselves accountable and how you all help us be accountable, and how are we going to follow and monitor it? So we've created this vaccine equity metric or vaccine equity quartile as a critical indicator of how we're doing. And we are, we just really all know and understand that the greatest disease burden is in our most impacted communities is in, we're using again as a proxy our Healthy Places Index, since we've used it before for our health equity testing metric. And again, 40% of the disease burden, 40% of the cases and the deaths are in quartile 1 or the lowest income quartile. So we're going to be monitoring very closely how are we doing in vaccinating that quartile and how does it compare to our highest income quartile. So these are going to be actually addressed as benchmarks in our blueprint by shifting our tier threshold to higher case rates once we get to certain benchmarks within that vaccine equity quartile. Actually I'll walk through those and then I'll tell you where we are in those two. Next slide. So here's how things will change. So right now we're at, and here's where I'll tell you. So we are at 1.75 million doses in the vaccine equity quartile statewide. So when we get to 2 million, that's our goal number 1, administered, then we will be actually shifting the red tier will become a little bit more liberal, basically. So we will be able to, more counties that are sort of between 7 to 10 will be able to do things that are allowed in that red tier sector. There won't be changes initially to the orange and yellow tiers. But then after we get to a next benchmark of 4 million doses administered in our vaccine equity quartile, then we will be shifting down to have some changes in the orange and yellow. And the idea, again, being we know we need to get vaccine to our most impacted. That's our fastest way to actually move forward and get out of this pandemic. And it's also what we need to do to address equity. So these are, again, the benchmarks we're going to be showing. We actually just also posted yesterday some graphics around this. So you can see how many doses. You'll see that 1.75 million, and that's compared to over 3 million in Q4. So the highest quartile is almost double the number of doses, and we need to fix that. The other graphic that you'll see on our updated website on the COVID-19 vaccine dashboard is that 6% of the Q1 that are over 16 have been fully vaccinated and over 15% with 1 dose. But that's in contrast to 13.5 and 27% of Q4. So again, we have progress, but we're going to be monitoring it together and doing all the things that our partners will be telling you about after I speak about how we're going to get there. I think actually that might conclude. And I think the last thing I'll say is we are, the other things that will be announced very soon, probably later today, is what are the other refreshes we're doing on this blueprint? What are things that, there are some updates as we think about the science behind, we've really got it now that this is an airborne disease and we really need to continue to be masking. We have updated our masking guidance. You've heard about the CDC double masking, and really fit and layers of masking are the most important, especially indoors. And that's the other big theme. Like, we know that outdoors is very low risk and indoors is higher risk. So really trying to allow more things outdoors, as we all know how antsy we all are after a year of enduring this pandemic and the restrictions that have been there. So lots of exciting news coming with that later today as well. Next slide. Okay, I think I will turn it over now to our partners at Blue Shield. Thank you.
Yes, and I see lots of questions popping up in the chat, and we'll have time. Some of those questions I think will be covered in part by the presentation from Marta and our partners at the TPA, but we'll have time to get through some of them as we move a little bit further on. And so with that, I'd like to go ahead and introduce Marta Green with the California Government Operations Agency to share more about equitably accelerating our vaccine distribution and administration for Californians.
Thank you, Dr. Burke-Harris, and I'm very excited to be here with you all again today. So thanks for having me. Next slide, please. Well, I guess we really had 2 intro slides, so next slide again, please. Okay, so what are we doing? Why are we here? What are we trying to deliver? Some of you have heard me talk about this before, but I just want to kind of level set again as we talk about where we are in the implementation of the third-party administrator. We are trying to deliver more options to vaccinate Californians faster. We want a big statewide network of providers. We want it to be geographically diverse. We want to offer home visits for those individuals that cannot leave their homes, mobile providers to reach hard-to-reach communities, and pharmacies to reach many different folks. We want more resources in our communities. We want our networks to be designed to reach the most vulnerable and those disproportionately impacted by COVID-19. And the allocation methodology change that Dr. Pon referenced earlier, I will get into more detail because I know there's been a lot of questions about how it's derived. We want to continue to support providers in our local health jurisdictions for costs that they incur that are FEMA eligible to be reimbursed. We want to help patient navigators direct hard-to-reach populations to vaccination so we can make sure we are vaccinating at a higher rate those disproportionately impacted by COVID-19. And we also want to help support different services that will make vaccination easier for those that are hardest to reach, including extended hours for those that can't make it during just the normal vaccination hours, whatever those are, additional language capability, accommodations for physical accessibility, and of course the mobile clinics, as I touched on before. Also very important to us is just a much more consistent experience with 58 different counties and 3 local city jurisdictions, all doing it slightly differently, all working very hard with their community. It's an inconsistent experience for Californians. So we want to have one place that all Californians can go to, so they know when it's their turn to get vaccinated and they know where they can sign up for an appointment. We also want to know from the moment a vaccine is ordered to when it enters the state, to when it arrives at a provider's location, and to when it's administered. We want to know everything about that vaccine. This is the single most precious resource we have in the state of California. It is life-saving. It is the thing that's going to allow us to open our economy appropriately and safely. And we need to know everything about it at every moment. So we need to have more transparency and data into our vaccine distribution. And we need to be able to look at this information daily and adjust our approach daily. So we make sure we're hitting those targets, that we are in fact vaccinating those disproportionately impacted by COVID-19. And we want to continue the ongoing robust community and stakeholder engagement that has been built today. Next slide, please. So this is, again, a little bit of our problem statement. So this is a few days old, but you get the picture. We have a gap between the doses reported as delivered to California and the doses administered in California. And some of those are appropriately in freezers awaiting upcoming appointments. But we know for a fact, in conversations with some of our provider partners, that some of these have been administered and we just lack the data. And without the data, we cannot judge ourselves. We cannot say how well we are doing against our goals of equitably vaccinating those most impacted by COVID-19. Also, as a result, first dose allocations to California have been completely flat. We are not seeing significant increases in supply other than the one-time increase of the new Janssen or Johnson Johnson. I've heard it referred to so many different ways, but the new vaccine, we have a one-time bump coming in. We do not have anticipated allocations for that. But other than that, we have been entirely flat. And we have to be able to demonstrate to the federal government our capacity to be able to equitably and quickly administer vaccines in order to ensure that our supply continues. So again, we want to hit our equity goals. We want to hit our speed goals, but we want to hit our speed goals in vaccinating the right people. And the right people are those most likely to be impacted and most disproportionately impacted by COVID-19. Next slide, please. So, there was an announcement and, there's a lot of talk about March 1st. And I think it caused some people to say, well, what really changed on March 1st? Well, some things changed that were important and some things didn't change. There was absolutely no light switch change on March 1st to the current vaccination network. All providers that were currently in the system and able to vaccinate were going to continue to be in the system to vaccinate. So we were starting to make recommendations regarding vaccine allocation to providers, in part based on how well they were performing in administering vaccine. And then, as you heard the governor announce yesterday, well, now my days are running together, but you heard the governor announce recently the way we switched vaccine allocation methodology to really concentrate those doses in the lowest quartile HPI tracks. And we developed that allocation methodology in partnership and really led by our colleagues at the Department of Public Health, but also working closely with our colleagues at Blue Shield. So we're going to be working with our existing provider network to get in a contract in order to agree to join my turn and perform in our performance management system. Blue Shield is working closely with every local health jurisdiction to create an in-depth transition plan to ensure that this is smooth. It's because we do not want any bumps in the system. We've got many things in the current vaccination system that are working well, and we want to continue to support those. We just want to build on the good work that's been having in the community and build the capacity to really be able to vaccinate at a very large scale. Next slide, please. So as I talked about, we kind of have carved the state into waves for onboarding, and we looked at a number of different factors about how we were going to decide which counties to onboard first. And we actually came up with a relatively thoughtful and scientific approach of how we prioritize the counties. And we looked at basically 5 factors. We looked at the percentage of the population that was living in the lowest quartile, right? So we've been talking about how important it is to target this population because of their disease burden. We looked at the percentage of the population that was eligible to be vaccinated. We looked at the COVID-19 cases as a percent of the total population. We looked at COVID-19 deaths as a percentage of the total population. And then we looked at the vaccine administration data. And with that, we were able to rank the counties and then bucket them into waves. So we were really trying to focus those counties to onboard first, where we thought we could have the greatest impact of getting vaccines into individuals faster in order to slow COVID case rate and death. Next slide, please. So this, I won't spend a lot of time here, but here's our waves. We started with a smaller chunk that had some of the higher case rates, that had some of the lower vaccination rates. We're pretty close to being done with wave 1 in the onboarding process. We are working heavily right now in the wave 2 counties, working closely with our local health jurisdictions on those transition plans, as I mentioned, that include a significant equity component. Next slide, please. So this is an example, and this is, again, a few days old, but this is kind of where we were and how we are thinking about our network development. So this is Fresno. So this is one of our wave 1 counties, and how we looked at geographic access and the different providers that were available to us. And so we were able to identify with those that were in contract and we were in the process of contracting with, that we actually had an area, a populated area in Fresno, that we didn't have access. And you'll see that it's a slightly purple, little purple splotch there. So in working with our partners in the local health jurisdiction, this is where we come up with some innovative strategies to reach that area, because we do not have adequate access. And so this is where we would consider the type of pop-up clinics, the mobile clinics that we can bring to bear to this community to ensure that they have access to this really important vaccine. Next slide, please. Okay, so this is the big change this week. So I'm going to spend a little extra time on the slide and how the calculations work, because there has been a ton of questions. So this is how allocation, beginning in the allocation decisions that were made this week, this is how it works. So the first thing that we do is we have to take a certain number of doses off the top, because we have certain patient populations that the state is directly in charge of. Those are those living in state hospitals and correctional institutions. This is not very large amounts, but we do take those off the top. We then have to prioritize clinically very important things like unmet need for second doses. So this is when a patient has reached the 3-week limit, or the 3-week or 4-week time frame, depending on which vaccine has been administered, and there's no second dose for them. And so we have to prioritize those so that those individuals finish their vaccination course of treatment. And we ended up with some second dose shortages throughout California that needed to be addressed most urgently over this week and the upcoming week. So once we deal with those kind of unmet and urgent issues, we then take the pool of vaccine and we apply a geographical weighting. And this is what we've always done. So this has been the approach that we've had since even when we were doing 1A, but we're doing it with the population that's eligible today. So we look at the over 65 population plus the 3 sectors, the first responders, food and agriculture, and education and child care. We weight that 70% towards the over 65 population and 30% towards education and child care. So with 80% of the doses, we spread those by zip code by eligible. So if zip code X has 1% of the eligible people based on this formula, they will get 1% of that 80% pool of the vaccine. So we just spread it evenly. And I call this the even layer. Okay. Then the next layer is you take that 20%, and this is the equitable layer. So this is when we spread it on the lowest quartile HPI tract to increase the doses to those tracks to 40% to match the COVID case rate and death for this population. So again, we take the first 80% and we evenly spread it to all the zip codes based on the eligible population. And then we take the remaining 20% and we equitably spread it to the lowest quartile HPI tracks. So that's that weighting, that's that 40% weighting. So once we make those allocations to the geography, we then split them up between the providers within the geography. Right now, that is the lion's share going to the local health jurisdiction and other major providers with whom we have a direct contract. As the state establishes more direct contracts in each jurisdiction, there will be more transparency into exactly which providers within that jurisdiction are receiving that vaccine. And we'll be able to do a better job at targeting directly to the zip codes that we're trying to reach. And sending doses exactly to those locations. Over time, we will continue to adjust as supply increases, especially be able to adjust those allocations so that we're maximizing the provider performance, especially in those lowest quartile HPI tracks. And last but certainly not least, second doses automatically follow first doses, and they're actually sent out on a different time frame. So on Tuesdays, generally speaking, is when allocations are posted for first doses. The second dose allocation process happens on Sunday. This this whole allocation methodology only applies to first doses because second doses follow those first doses to whichever provider provided the first dose. Next slide, please. And with that, I'm going to turn it over to my colleagues, Kimberly and Peter from Blue Shield, to take it from here.
Well, thank you, Marta, and good afternoon, everyone. I'm Kimberly Good, and I am the Senior Vice President of External Affairs for Blue Shield, and I also serve as our chair of our Diversity, Equity, and Inclusion Leadership Council, and I get to co-lead our equity practice with my colleague, Peter Long, who you will hear from in just a moment. We are here to talk a little bit more about the work of the TPA and my role in supporting the third-party administrator process is serving on the communication, education, and equity work streams. In this capacity, we work really closely with all of our state partners and local health jurisdictions to ensure that, as you've already heard, we are building on what has already existed to ensure that we optimize the current network and offerings as we seek to expand it and accelerate the work that we're doing. Our goals in this process is to ensure that we are building on what's working well and that we work together to identify those things that will enhance how we allocate and support the vaccine process under the direction of our state partners. We want to make sure that we are fully embracing what everyone on this call is, which is to ensure that we save more lives and that we do that in a way that is equitable. That's going to require us to use more data and to also tap into the expertise of those on the ground. And that's why we're being so diligent in how we approach this work with lots of points of connection. Everyone has been very generous with their feedback. We appreciate it. And we are doing meetings with every single local health jurisdiction and a number of other stakeholder groups. If we go to the next slide, this will really illustrate for you what we mean by this being a build. This 5-point plan should be very familiar to the group. We didn't create it. We have embraced it as part of the state's approach to how we are approaching vaccine equity. And just as we do as a company where we embed a diversity, equity, and inclusion focus in everything we do at Blue Shield, we are embedding that in everything we do as the third-party administrator for this process. So as we look at this, what I'll just spend a few minutes on is talking about what that means from a Blue Shield TPA perspective as it relates to each of these 5 points. On the allocation side, certainly we'll be using the data to make recommendations to the state. Really important that we all have clarity that the final allocation decisions will be a state decision, but certainly we will be supporting all of those efforts to ensure that our equity goals are met, whether it's through the prioritized approach for the allocation, as well as any other expectations set by the state. You know, most of our energy is really focused on making sure that we enhance the network. As you've heard, there are no changes to the network today, and I'll talk about some of the progress that we have in the transition. But ultimately, our goal is to make sure that we have a very robust network, provider network, that helps us achieve our goals and certainly helps us reach all of the hard-to-reach populations that are important to us. As we think about the community partner section, that's not an area that we're accountable for, but we are in partnering with our state partners to ensure that we have the necessary outreach and support for for communities that are disproportionately affected. The same with public education. Again, that's a partnership piece where we're not taking the lead. We certainly do have a role with regard to timely data and analytics, as you heard Marta describe. We want to be able to use the data to validate that we're getting the vaccine where it needs to be. We're getting it out there as fast as it needs to be out there so that we're being very efficient. And having that data is going to allow us to adjust as appropriate. So we certainly will be playing a lot of goals there. From a principal perspective, we intend to be transparent and making sure that that data is accurate. And that's one of the reasons that you have had the big push on My Turn, because having that single place where information is coming in and housed will enable us to be accurate and timely in that data. If we go to the next slide very quickly, because I know that Bobby said we run a tight ship here. Here's some points of progress for us in our first wave. We announced when we talked about the transition that there are 3 waves, and there's a whole process of determining how we prioritize counties. In essence, we were prioritizing counties where we saw the greatest need for us to get in and try to close gaps and enhance what's there. So we have met with all of the Wave 1 counties, and we've already secured about 1,000 sites that are in that network. We have all the multi-county entities contracted except for 1, and this changes by the hour, so who knows where things may be at this point. We've got additional Optum locations that are identified. Wave 1 FQs are under contract, those that are currently vaccinating. And we're also finalizing, very, very close to finalizing the details with Homebound and other providers to serve the disabled community. And then lastly here, as we mentioned before, we are working very closely with all of the local health jurisdictions, in particular on equity plans that will ensure that what's in place engages the community-based organizations, and where there's a need for additional supports, we can work together to identify and ensure that's captured. So I know that there's a lot of interest in digging even deeper into how we are going to help support the achievement of the equity goals and working with the community. So I want to turn it over to Peter Long to provide a little perspective on that.
I'm having a COVID moment here. 1 second. Why don't you take the next slide and then I'll come back. It's a COVID moment. 1 second.
All right. So this slide is just for your, can you guys hear me okay?
Yeah, we can, Kimberly. Thank you.
Yep, and we'll keep it moving here. This is Peter's favorite slide, so I'm so sorry that his dog interrupted, but this is just an overview of sort of a picture's worth 1,000 words. So the goal here is to show what the coverage would look like from a network perspective, as well as identifying the partnership between statewide organizations, regional organizations that serve multiple counties, those that serve Northern California. And this is an example of the kind of data that we want to be able to gather and show so that we have a complete and integrated approach to delivering vaccines in an equitable way. Next slide. Just shows again how this is an iterative process, and it's not something, as you all that have been in this game since it started understand, this is not something that is once and done. It's iterative. Data evolves, circumstances around the virus evolve. So we want to make sure that we have an iterative process that is well coordinated and dynamic to meet the needs of the communities that we're trying to reach. And we know that that's going to rely on feedback mechanisms, and that's what we're trying to illustrate here. A lot of this work is not under the direct control of the TPA, but it is a partnership that we do with our colleagues in CDPH and on the state side, so that all the great work that they are doing from a public education, a CBO perspective, the recent cohort that was just announced, we together are making sure that all of that is harmonized in a way that achieves our goals. The next slide, which is, I believe, our last, is really just a way of reiterating what we've said multiple times. Our commitment is to be a partner in the process. We know that there are a lot of questions, there's a lot of speculation and concern. I will simply say to you that Blue Shield's only interest in being in this process is to exhibit our care and concern for the health and well-being of Californians, and we are committed to partnering with all of you and our state colleagues to do all that we can to help get behind this pandemic so that we can restore our state and our economy to where we want it to be. So I think that's our final slide. And with that, I think, Bobby, you wanted to open it up to some questions.
I think before we go there, we have Andy Patterson from the California Primary Care Association to talk a little bit about how the federally qualified health centers and other community clinics are going to be involved in vaccine distribution. So we'll go to the next slide, and Andy, welcome.
Great, thank you. So this is on the federal, but I'll just comment really briefly on the Blue Shield partnership. So we're talking all the time, and I thank the Blue Shield team for allowing me to hound the many staff that you have working on this. And I think we are making lots of connections. We're working to try to ensure that every clinic and FQHC that wants to continue to vaccinate and participate in this effort can do that. And so CBCA is helping to make sure that all those connections are made, and appreciate the Blue Shield team for really doing everything that they can to make sure that that happens. We have yet to fully resolve the issues with MyTurn. I think there's absolutely, I'm kind of a tech geek in policy. Love the vision. It's really hard to implement. So we're working through all of that. I'm sure everyone knows that not all health centers use the same system, though our best efforts to try to make that happen many years ago. Then you have to try to adapt those systems to new technologies. We're all using different versions of different EMRs. So our goal is to try to create a seamless process with MyTurn if we can, but definitely appreciate the state's goal at real-time data, daily feeds. That vision we appreciate, and we're going to try our very best to make that happen, and appreciate the Accenture team and Blue Shield trying to help us do that. We have many nuances to work through in terms of private clinic and things like that. On the federal side, and separate from what's going on at Blue Shield and at the state level, FQHCs like pharmacies are getting a direct allotment, and we're really excited that the Biden-Harris administration is taking advantage of this amazing federally qualified health center system and Indian Health Services system that our country has invested in. And there are over, FQHCs are serving, I think, about 30 million people in the country right now, and we are going to leverage them. So to date, you'll see, I won't walk through the numbers, but 5 of the first 25 in this program, it's not a pilot, it's a program, we're in California, and the choices of which FQHCs were participating first were really based on special populations, so ag and homeless of particular note. More and more health centers are going to be onboarded. The Wave 2 cohort has started to receive vaccines. Wave 3 has ordered, but has yet to receive any. So we'll start seeing this happen. The state, we're all aware of this. We're trying to triangulate whether or not, how to integrate what's coming in from the feds with what the state can see that the state is getting. Our push would be that we just have this as an added bonus, that it doesn't detract from what FQHCs can get at the state level, so that we can further double down on the 40% commitment that the governor made yesterday, this week, because health centers are all located for the most part in a medically underserved area or serving a medically underserved population, the focus of all of this equity work. And yes, health centers can get the Pfizer, but only the very few have the cold storage. Most are getting Moderna, and then J&J will be coming out. And I believe that there is ability to choose when they start ordering. So just wanted to acknowledge that is happening, and we are really excited about the opportunity to participate in ending the pandemic quickly. Thank you, Bobby.
Thank you so much, Andy, and for that highlight on the vital partnership with our federally qualified health centers. And now I want to jump into some Q&A so we can have Bobby facilitate that. I'm going to start with 2 questions that I know off the bat are from Marta. One question is, when we're talking about pay for performance and the criteria in the TPA contracts with vaccinators and the equity plans for vaccinators, does that include pay for performance or metrics for serving individuals with disabilities and pre-existing conditions? And then the second question from Marta is, were some of the some health centers were reporting reductions in supply recently. Is that due to the TPA or is that something else?
Sure. So I'll take the first one first and the second one second. So the first one, so when we originally started this project, we thought that pay for performance, having some sort of incentive payments for reaching targets was the way we were going to be able to achieve our goals. And what we've realized that that's not really it. What is that providers need support to reach our target communities. And so what we're doing as part of the onboarding process is providers can basically say, here's my plan. I want to help you reach your target communities, whether we're talking about the lowest quartile HPI tracks, whether we're talking about hard to reach communities in some other capacity, whether we're talking about farm workers, whether we're talking about people with disabilities. And here's my plan. But what I need from you, state of California, in order to support that is I need resources to support these additional staffing, these additional physical costs, and the state has built a process, and we've talked about this as part of our plan to upfront those costs to allow those providers to get into the community. Long-winded answer of saying that yes, targeting people with disabilities and those with comorbid medical conditions is one of the things that we can fund. Second question. Remind me, Dr. Burke-Harris, I'm so sorry. Oh, it was reductions in allocation to FQHCs. That's what it was. Yes. So week over week, so the allocation decisions that went out this week from the week prior for local health jurisdictions, they were flat or up. They were either flat or up. Nobody went down. However, what I will say is the mix of vaccine changed. So we had lots of local health jurisdictions that received either less Pfizer or less Moderna or less of both and J&J. So I can't speak to what happened to the specific FQHCs or community clinics that may have received less, but I can suspect that if the mix changed and they were receiving one of the different vaccine types, that it is possible that because the mix changed when they were sub-allocated, something could have changed in that regard. But as far as the total allocation between all three vaccine types, no local health jurisdiction went down. Everybody either stayed the same or went up. Those that went up were those that have the larger concentrations of the lowest quartile HPI tracks.
Okay, thank you, Marta. Really great to get your feedback on these issues. So we're going to start with Dr. Jeffrey Luther, and then we'll go to Dr. David Lown, and then we'll go to Kieran, Jenny, Ronnie, and Aaron. So that's where we'll start, just so you know where you're coming, and then we'll see if we can get to everybody else that's interested in questions. Make sure to introduce yourself so everyone knows who you are, particularly members of the public who are listening in. Jeff?
Thanks, Bobby. I'm Jeff Luther, representing the California Academy of Family Physicians. And my concern has to do with prioritization among the 16 to 65 with comorbid conditions group. We're already in my practice getting phone messages and emails saying, hey doc, I have asthma, I'm obese, when do I get my shot? Or can you send me a letter so that somebody who's giving out shots will know that I deserve one? And we're getting lots of messages from our constituents, family physicians around the country, and from our parent organization that the prospect for a deluge of patient communiques kind of taking over the workday in place of patient care time has a lot of docs worried. So my concern would be that as this is trotted out and as we have delineated what those qualifying conditions are, it needs to be as clear and straightforward and well communicated as anything we're doing. And it really ideally needs a way to be administered so that it's not dependent on physicians and nurses rifling through patients' charts and writing letters and notes on a random process.
Okay, that's a great question and an important one. Marta, Kimberly, Erica, who can help us understand how this is going to work?
I think this one's a bit more appropriate for our colleagues at the Department of Public Health. Dr. Pon, if I'm mistaken, please correct me.
Sure, that's fine. I think, I did try to mention this when I was talking about the different conditions, and that we have an implementation work group that's working really hard on this. We know this is a concern and an issue, and we've seen some templates from our local health department colleagues about eligibility, but we know this is a concern, and I think we do have a couple more weeks I guess it's only 10 days, but so we're working hard on that, and there will be more communications coming, but we have a stakeholder group about implementation with, again, many crossover from people on this committee as well. So stay tuned on that. Thanks.
Thank you, Erica. And thank you, Dr. Luther, for raising that issue. David?
Sure. Hi, thank you. This is David Lown from the California Association of Public Hospitals and Health Systems. Quick question for you, Marta. Did what you described in terms of the support systems to providers to meet the equity goals with plans and then requested support, does that mean that there will not be P4P incentives, or is that or P4P incentives on a separate track? And if so, what are the details on those incentives?
So we still have room in the contract to develop specific pay for performance incentives, but so a couple of things. Number one, they're not FEMA reimbursable because FEMA looks at the administration of the vaccine as the reimbursement. And so that's one issue. The second issue we have is everybody wants the vaccine right now. There is no provider that is saying to me, don't give me an allocation. And so it appears to us at this moment that really what we need to be doing is giving them the support that they need in order to administer more of it, right? Administer more of it to the right people, or administer more of it to the right people in the right places. So that's why we really think the effort is better spent in these upfront costs to allow providers to get mobile, to allow providers to do in-home, to allow providers to reach those communities, as opposed to saying, well, since you vaccinated 10 people in a zip code, that's what we're paying. We don't see that as the most effective approach to reach our target communities. We really want to target it towards getting the vaccine to the people that we really want to get vaccinated. And that's why we think the upfront payments are a better strategy.
But still a possibility that P4P could
Still a possibility P4P could exist. It's just in this moment right now, it looks like the upfront cost is the better investment.
Great, thank you.
Great. Thank you, David. Great question. Karen, let's go to you, and then we'll go to Denny. Denny's only going to get one question this round. Remember, Denny. Go ahead, Karen.
Sure, I'll be really quick. Karen Savage, California Pan-Ethnic Health Network. I don't have a question. I actually just want to offer my gratitude, appreciation for the really strong, I think, move towards equity. Yesterday or the day before, I've lost track of time. I think, I feel that when you're critical in so many meetings about the equity, you have to give the praise where due, and I really do appreciate it. And I know there's a lot to be worked out in the implementation to really see the results, but I really want to give my appreciation to the team at the state who's worked so hard on this, and I think it's really the right direction. So thank you.
Thanks, Karen. Okay, Denny, one question. Not four, collapsed into one.
All right. Hi, everyone. Thank you, Bobby. Denny Chan from Justice and Aging. I have one question followed by a couple of points that I want to make. So the first is to echo what Kieran said. Thank you to the state for really putting its money where its mouth is, or its allocation where its mouth is in the 40% decision. Wholeheartedly support that and appreciate it greatly. Two process points before I get to my question. One is, I believe at one of the previous CVAC meetings, we had said that we wanted heads up on policy changes, and would just reiterate that heads up to the extent that you can do it. It would be really helpful to find out through things as a member of the CVAC and not on the evening news. And then two, to the extent that we have lots of things to talk about as we are rolling this out, as I know we do, and why the agendas are so cramped, I would be in favor of actually going back to 3-hour meetings if it means we can actually do a deeper dive on some of these issues. I understand that there are long meetings, but I think with an appropriate amount of a break, it allows us to better leverage each other in terms of learning what the state is doing and giving feedback. So those are two process points. My question really is about data related to older adults of color. This is a point that I feel like I've become a broken record on, but I think is really important. The administration has said they want to learn fast and learn quickly in responding to the COVID-19 crisis. South Carolina and Washington are ahead of the game. They've already learned, and they're giving the public vaccination rates broken out by age and by race, intersectionally, both of those factors combined. So my hope is that in moving to the TPA, one of my understandings is that we would get better data and faster data. I saw in the fact sheet that was released earlier this week that there is a commitment to do it. So my question is, when can stakeholders expect to get that data?
I'll start with that one. So part of the transition that we're going through right now is bringing all of those providers onto that MyTurn system that is going to give us that real-time transparency. So it is a process. I wish I could snap my fingers and all providers would be on the system and we would have that level of transparency into the data right away. It's a little bit more of a process. So I think that at the last time I checked, we had 1,600 unique sites statewide that were actually in contract, and we're in the process of working through getting all of those folks onboarded into MyTurn. And when that happens, that is that system is integrated with MyCA and the different inventory management and ordering systems that we have, all the way to the back end to the vaccine registry. And so what that'll allow us to do is for every provider that is in the network and on MyTurn, we know when the vaccine is in transit to the provider, when it's sitting at the provider, when it's administered. So we will be able to see that and who it's administered to. So for those network providers, we will be able to provide much greater granularity of data than what is available today. However, we do have some rich data already, and there is a lot of data in the existing vaccine administration system or databases. We just know that we're missing chunks of it. We know that there is vaccine that has been administered that is not in the state systems, and so that's the piece that we are really trying to solve, so that we know we can really judge our own performance.
Can I just follow up on that? I thought the state had, by race and age at that specific intersection, that you already have that data. It's just not being released on the dashboard. Is it that we need to get the network providers on board to get that data, or do you currently have the data right now?
I'll sort of respond. I mean, I think actually, so again, the HPI data finally went up yesterday, and I think that is our next step that we're absolutely talking about, like, you know, on an ongoing basis. So again, just acknowledging we've had a lot of data challenges with the decentral process of our healthcare systems and our, you know, so I think as this has been kind of a challenge all along of getting good data. I will actually I saw in the chat as well, people asking about the sexual orientation, gender identity data. I can also say that there's a lot of just behind the scenes issues around the way data is transferred between electronic health records and other data systems. We've had a challenge with that data, even for cases. So we have a huge chunk of that missing, and it's a very national sort of technical issue around how data is transferred in HL7 messages. But we are planning, even before during this transition, to start to post more by race and ethnicity. So we're just kind of trying to do this in a stepwise fashion. We always are trying to balance as well how clean our data is, how good it is, and you know, trying to validate with our county partners who actually have sometimes more granular data. And then if we have something that looks really different, we want to try to validate. So we've been working really hard on that behind the scenes, and we may have something, you know, we're hoping to have something much sooner to that point. But we're very excited again that we at least have our HPI metric, and we're doing that by HPI, which, as you know, correlates quite well with that. But now we're trying to cross-section all that. So continuing to work on our data and posting on that. But we also want to make sure when we give it to you, it's good data that we can validate. And so not trying to rush it out there until we know it actually, we have confidence in the data.
And thanks, Denny, for the process points. We are definitely have those two issues top of mind and have been talking about both as we try to push data and information out to you as quickly as possible. And we've been talking about the meeting time again. So thank you. So let's go on to Ronnie, and then we'll go to Aaron. And we're going to extend our time for this section just a teeny bit so we can take a few more comments. And then if we have more time later, we'll come back because I see everyone who's wanting to talk in the next section, and we won't get to everyone. So go ahead, Ronnie, and then Aaron. Don't forget to introduce yourself.
Thanks, Bobby. Ronnie Kelly, County Behavioral Health Directors Association. This is really a point of clarification I'm asking for. Dr. Pond referenced to check back on the priorities, and then Marta, in your slide number 23, it talks about finalizing details on options for homebound and disabled Californians. So I wonder what the time frame was for this clarification, knowing that it is imperative that we ensure that disabled includes behavioral health, serious mentally ill individuals, and substance use disordered individuals who are at high risk of both morbidity and mortality, and would meet each of the 3 comorbidity or subpoints.
Marta, you want me to take that?
Yeah, I wasn't sure if it was related to the documentation question that has been raised earlier. I guess I wasn't, are individuals in these categories include, I wasn't entirely
that's
sure.
What right. I know Dr. Aragon said that we would address this gap, that people who have a serious mental illness, in particular those with schizophrenia, having the second highest morbidity behind a mortality rate behind age, that we are going to be able to call out behavioral health, serious mentally ill, and substance use disorder folks as disabled individuals.
For the 315. Okay. Yeah, we really should defer to our colleagues at the Department of Public Health on eligibility questions.
So, and I think just on that note, the drafting guidelines work group is taking a look at a lot of the conditions that advocates and others have put forward to consider again. So we'll have more updates from that advisory group moving forward as well.
Yeah, that's at the top of the agenda for drafting guidelines today, Ronnie. Let's go on to Aaron.
Thanks so much, Bobby, and thank you, Dr. Burke, Harris, and Pond, for all of the work. Thank you to the state for its continued commitment to equity. What was announced this week really was creative, inclusive, revolutionary, and I'm glad that the other states are noticing how California is doing what they're doing and taking tips where they can, including South Carolina, using some of California's language around developmental and other disabilities. So thank you for your leadership and how it's leading us here and spreading to other states. 2 pieces of feedback. One is that we're hearing comments from the community of people having long waits to get through My Turn, whether they get timed out at the portal or they're on the phone. So if you can please monitor and staff up to meet the response that's coming. Thanks, Marta. See you nodding. Appreciate you got that one. Also, second, regarding communications, we're really going to need something that just explains clearly to the public, here's how you get a vaccine. There's multiple routes. And just something plain and simple that just says, okay, I'm eligible, I need it, I want it, here's how I go to get it. My question is, so that's a suggestion. My question is that we're in a time of scarcity and we're building a system during a time of scarcity, but soon there will be abundance. The end of May is not that long away. What are the projections to see what's coming into the state? So we start moving out of this, who's going to get it, who's not going to get it, who might get pushed aside as other communities become eligible on March 15th. We're not wanting to see any of that. We want everybody who's eligible to get the vaccine, and it's all about supply. So what are the projections between now and the end of May to get everybody vaccinated per the president's promise? Big question. Thank you.
Go ahead, Marta, if you want to start with that one.
Well, I was just, it's really challenging as far as I can tell. And Dr. Pond, I invite you to correct me, but, when we look at what the concrete information we have, right? So we have what's being said and what we hope is true with respect to supply. We really want it. We want it to come into the state desperately. We want to get people vaccinated desperately, but the real concrete information we have is that 3-week projection we get from the CDC. And I hate to tell you this, but it is entirely flat. There's not a single dose increase, not one. And there's no Johnson & Johnson or Janssen or Janssen. There's none in the outlying weeks. And so what we are going to feel is a decrease over the next 3 weeks. So supply is going to feel more constrained. And it's just, for me personally, is cognitive dissonance. We're having this public conversation about an increase in supply and this strong push to get everybody vaccinated. But in the short term, what we have is this 3-week projection that's flat. What I'm hoping is that when those allocations actually come, that what's allocated is over that projection, that it's an under promising and over delivering. But all we have right now is that 3-week projection from the CDC. Dr. Pond, I don't know if you want to elaborate on that.
I mean, I would echo that, and that the concrete of only 3 weeks, and that what we have been trying, I think, in partnership, with Blue Shield and a subcontract, they have to really look at these projections, and I think we're really, I think we're all on the same page about that, right? We want more vaccine, and we want to get to a place where we can liberalize it. And when we look at these different projections that change week to week, we try to look at, when, after March 15th, I think I saw a question in the chat about when can we open to like the next age cohort. And so we're continuing to try to do that, but it has been very challenging. And the administration had also said, the Biden administration, that they would do that longer term view. But I think it's a moving target for them as well. It's really exciting news this week. So hopefully we'll see more of the actual numbers very soon about, what that partnership with Merck is and how that's going to increase. But in the short term, it's true. I think it's really, we're in a hard spot now. We need to get second doses in. And if we're flat, it means a lot less first. So that actually answers some of the other questions in the chat as well about just some of the constraints we're seeing. But, I think we're all continuing to advocate as best we can.
Thank you. We're out of time for this section of the agenda, and I know we have 5 more people who wanted to comment at least. Linnea, Anthony, Sylvia, Esther, and Diana. So I'm hoping we're going to have a little more time at the end of the next piece of the agenda. We'll see how we do. And we'll come back for sure to you all. I've got it all recorded. So I apologize that we don't have more time now, apropos of Denny's well-stated comment. So Nadine and Erica, back to you.
I think now we're going to have an update on the Johnson Johnson EUA. And so I will pass it over to Dr. Pan to comment on that.
Great, thank you very much. So as we've talked about a few times today, super exciting news about the Johnson Johnson emergency use authorization. Next slide, please. Our Western State Scientific Review Group did actually meet on Monday night after the ACIP, this Advisory Committee on Immunization Practices, had met on Sunday and Monday, both to review their input on the safety and efficacy and also thinking about other unique aspects of this vaccine. So, and we, again, just to reiterate, we're very lucky both within our state and then to have this partnership with Washington, Oregon, and Nevada to have a lot of really outstanding scientific experts, many of whom sit on either this committee for the CDC Advisory Committee or the FDA committee. Next slide, please. So I think, as just to kind of talk about a lot of the key points for this vaccine. Like Pfizer and Moderna, this vaccine is safe and highly effective against preventing death and severe COVID and actually hospitalization. So there were actually no deaths in the vaccination arm of this trial of about 40,000 individuals. I got to listen in on Monday night to hear our experts talk about this vaccine, and I'm really excited about it. Again, I know there are numbers out there about the actual infection, but they're very different as far as comparing the way they look at that data. And the most important data about severe, again, hospitalizations and death are really excellent, like over 90% and then no deaths. So technically it could be considered 100% against death, but it was a small number. The advantages, as we've been hearing, throughout this meeting, are that this new vaccine is just one dose. So it's a one and done, which I think is very exciting as well. It's easier to transport and store. It can be stored at standard refrigerator temperatures. So it's another really important tool for helping to end this pandemic. Some other unique aspects about this vaccine actually are that they actually, unlike some of the other trials, they did some data collection to try to see if they could decrease asymptomatic or people with no symptoms infections, and they did. So, there's been a lot of back and forth about, how much of vaccines decreasing transmission, and there's data that this vaccine does decrease transmission amongst recipients. And what's really interesting is it performed very well against variants. So that's a really exciting piece of news as well. So I'm personally very excited about this. I think it is unfortunate, as Marcia said, that we do have one allocation that's coming, that's being ordered, but it's only about 300,000 doses. And then after that, our allocation is looking empty for the next 2 weeks. So we're trying to understand what's going on with that and hoping that there will be a flood after that, but really gearing up. I do want to also mention, a lot of conversations have been happening both here at the state and I think nationally about, whether this vaccine should be prioritized for certain populations or not. And I think we really look at this as one of 3 excellent vaccines. And I think looking at different aspects about storage and transportation are important considerations or other unique aspects. But this one is equally, validated in all populations. And one of my colleagues, Dr. Liu, just mentioned, the other great news as far as just logistics around vaccine distribution, that Pfizer also recently now has authorization from the FDA to be stored at standard freezer temperature instead of the ultra low temperature for up to 2 weeks. So that's also going to help just, again, getting vaccine into additional providers that maybe haven't had those resources. So really will help us, I hope, get to some of our equity goals as well. Let's see, and then, did I mention too, I think it does seem, again, early data, but then maybe there's less side effects as well with the Johnson & Johnson. So again, really an outstanding vaccine that we're really excited to add to the mix. And then one last comment from the scientific point about this vaccine is that it does take probably about 28 days after the first dose is about when you're protected. So, and it's an important message in general about vaccines. For the other 2-dose regimens, we really consider protection about 2 weeks after that second dose. So the kind of advantage of the 1 dose is that you'll be protected about 4 weeks after starting, as opposed to 5 or 6 weeks after starting the Pfizer or Moderna. So those are my updates about Johnson & Johnson.
Great. Thank you, Erica.
Sure.
Let's see if there's any questions specifically to Erica on the Johnson & Johnson or the Johnson EUA. And then if we have time, we'll go back to the folks who had questions from the last section. So let me just check in with the people who've got their hands raised, because I know you were left over from the last session, but you might have a question for Erica. Sylvia, Diana, Esther, Linnea, Anthony, for Erica, anything on this issue, and then we'll go back to your questions on the other issue. Okay, anybody have any questions on the J&J vaccine for Erica? Please raise your hand.
One last comment I'll make as I'm looking at the chat is just, I did mention again, there's been a lot of deliberation about whether to prioritize this vaccine for certain populations. And I think there will definitely be logistical considerations that are going to be implemented. I think with some of the concerns and confidence based on the numbers that have been out there about efficacy, we also really want to make sure that everyone has equal confidence that all 3 of our vaccines are excellent vaccines and good choices. And again, there might be considerations based on the logistical considerations that are very important. But as far as safety and efficacy and ability to protect people, we want it to be really clear that all 3 of these vaccines are great. The best vaccine is the one that you can get, which lays into some of your points about, yes, there are certainly going to be considerations about persons who logistically it'll be easier to reach given 1 dose versus 2 doses. But again, really want to make sure that everyone understands and hears that, from all levels, we really feel good about all 3 of these vaccines in all populations. Thank you.
Thank you, Erica. Okay, we're going, let me just check in with Crystal. Crystal, was your question for Erica on this topic or the last topic?
Yes, it was on the J&J vaccine.
Good. Introduce yourself, Crystal.
Hi there, Crystal Crawford from the Western Center on Law and Poverty. Hi, everyone. I just wanted to lift up, I just spoke on a panel, COVID vaccine panel last weekend, and there is a push amongst a sector of Black doctors to really boost people's confidence in the J&J vaccine because of the perception that maybe it's like a second-class citizenship vaccine, and actually to tell people why people have even more confidence in the J&J vaccine because it does not use the mRNA technology, which is new. So I just wanted to make sure that that was on our radar and that that movement is happening to really kind of maybe overcorrect a bit for some of the lack of confidence in the J&J vaccine as kind of a latecomer, or because it has, a less, appears to be less effective rather in terms of the percentage of protection.
Thank you for lifting that up. And I absolutely, that is what we, I think is really important, and we hear you. And, I just want to say one more time on that note that this vaccine, as far as protection from hospitalizations and deaths and severe infection, is as equal as the Pfizer and Moderna. So that is really important to know. I think it's for the protection that is most important about severe infection, it's just as good.
And I want to speak to one question that came up in the chat. It was, if you get J&J now, does that preclude you from getting an mRNA one later? If you get J&J, it's one and done. You're fully vaccinated. So you will not be getting a second dose of anything, because one dose is a complete vaccination. And I think that's one thing that I also wanted to flag, as we were just realizing that, we heard from Dr. Pond that the state is planning to get, we'll be getting about 300,000 doses of the J&J coming in, and then we'll be flat for a little while. But I also want to recognize that 300,000 doses of J&J is like 600,000 doses of Pfizer or Moderna when we're talking about the number of people who can get vaccinated. So again, just thinking about what that what that means and how exciting it is that we have a safe, effective one-dose vaccine.
Yeah, thank you. And I think just because I'm seeing it in the chat too, just on that note, as far as there are discussions about, well, two things. Anytime you get one vaccine series, both with COVID-19 vaccines and other vaccines, it's really best to use the same manufacturer, just because that's what's been studied. So we really, really recommend that people use the same manufacturer in series. And yes, as has been mentioned in the chat, I think there's a lot of discussion, and as we watch for variants and do our detection of that, there's some discussion about if there are vaccines that are less efficacious and against certain variants, that probably what the manufacturers can do, and many of them are working on, is develop a booster dose. So that could be in the future a reality for Johnson & Johnson, in addition to the Pfizer and Moderna. But that is still very early in the stages of need and technology and manufacturing. But it could be, who knows? We get a flu vaccine every year and boosters, and it's a similar idea to kind of potentially modify vaccine and get boosters over time. So more to come on that.
Great, thank you all for those comments, and let's go back to Linnea, and then we'll go to Anthony, and then Sylvia and then I know that Esther and Diana also have comments. Let's see what we have time for to go back to our earlier conversation on distribution. So Linnea, why don't you go first? Make sure to introduce yourself.
Yeah, good afternoon, everyone. Linnea Koopmans, interim CEO with the Local Health Plans of California. My predecessor, Brianna Learman, formally participated in this group. So in part, this is an introduction, and I'm happy to join you all. But mine is actually a comment and not a question. So like others have already stated, I think local plans really appreciate and applaud the new equity-based allocation methodology and the announcement made earlier this week. I think has been previously discussed in this group, many of the individuals living in those lowest quartile zip codes or census tracts are Medi-Cal beneficiaries, and most of those are local plan enrollees. So my comment is really on the outreach to these individuals and the strategy and plan for ensuring they can access vaccines, and just highlighting what local plans are currently doing, kind of anticipating the focus on this population, and then also anticipating the increase in supply down the road. So already local plans are identifying beneficiaries who are eligible, and then sharing those with our provider partners and doing direct outreach, calling the members to make sure they're aware they're eligible, and then connecting them to a vaccine appointment. So as the rollout continues with both the TPA and the new methodology, I think our hope would be that this partnership and work that's happening collaboratively locally between the counties and their providers and the plans can continue. And then also just noting that, because I think we can be an additional resource in addition to the CVOs who will be doing a lot of that work on the ground as well. So just a comment, and I think looking forward to continuing to partner on that as we anticipate, an increase in volume in the coming months.
Thanks, Linnea, and welcome aboard. Anthony.
First of all, thank you for the efforts on equity this week. Thank you for answering that question about J&J and second boosters. I do think that it would be helpful for messaging and maybe providing some reassurance if there is a possibility of a second booster or something later on. I think people want immediate help now, but if they're thinking they're foreclosing some something in the future, or if there's a possibility of something in the future, I think that would help in the messaging. And I know that all the medical stuff is just so new, but the more that there can be some clarity to the public, I think that would help in doing this. My question was just, on the sort of things, I wanted to just get clarity, because I don't feel like I have it, about where are congregate care settings in the prioritization. Is it something that is in the framework? Is it not? Is it something that counties are allowed to do, or is it not? I just don't. I've gotten conflicting things, and I would just love if there was. I understand that there was an issue about like congregate care settings where there's multiple jurisdictions, federal, state, like the immigrant detention centers, and that's a question. But I would just be curious with regard to the other things. And then the second question I had was just, this week there was an issue with Sutter having to cancel a bunch of appointments, and I realized that the supply issue is significant. But I'm guessing, will the My Turn system fix the issue that when those cancellations happen, and they're going to, if we are going to be in a continued effort of scarcity, that there is sort of either easy rescheduling or like the one-stop shop kind of way to make sure people had information so they're not left like they don't know what to do.
Bobby, do you want me to step in on that one?
Well, I think maybe we should start with Erica, if she doesn't mind, to talk about where congregate living facilities that are under the state's jurisdiction fit in the prioritization. And then Marta, it'd be great if you wouldn't mind.
Yes, this is an ongoing issue that I think we are very close to addressing. And I do hope we will have more information very soon. It's a high priority for us in general to address the high-risk congregate settings. And I don't have an answer for you today.
Okay, we will see if we can push everyone to get to be able to talk about this in more detail at our March 17th meeting. We'll keep our fingers crossed. Just know, everyone, that we're pushing and Erica's pushing, and everybody's working really hard to get this very important question resolved. Okay, Marta, on the Sutter supply issue.
Yes, thank you. That's a great question, Anthony. So My Turn's going to help on a number of levels with the Sutter situation. Foundationally, what caused a lot of the problems at Sutter is actually the lack of clarity on their inventory. So the inventory numbers that were in the system were much, 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 much higher than what was actually in their freezer. And so what ended up happening is less first doses went to Sutter as a result of excess inventory. When that happens, they used second doses as first doses to keep their appointments. So when they used second doses as first doses, they didn't have second doses that came as second doses for those second doses that were used as first doses, which just created a very difficult cycle and something that you can't get in front of. And so what My Turn is going to do is both better able to communicate to patients and get those appointments rescheduled. So yes, it's going to do the thing that you said, but it's also the inventory management strategy. So we don't have the problem to begin with.
Okay, thank you, Marta. Sylvia, and then we'll go to Esther.
Hi, this is Sylvia from Disability Rights Education and Defense Fund. I wish I had Denny's capacity to hold multiple points and questions in my head, but I just have the one, I think. And it relates to what Marta was saying earlier about incentives. It's great to hear that, and I'm really looking forward to the TPA being able to provide technical assistance and funding for accessibility for people who can help with accommodations for staff, etc. I'm wondering if some of that can also go towards technical assistance and help on getting data. And it may seem like this, well, data is not the most important thing, but it's so vital to, I think, in so many ways. And we've had the plane analogy, right? We're building the plane. So of course you build the most important parts, the engine, the wings, and maybe it seems like data is not an existing thing. It wasn't in the plane before. We haven't collected sexual orientation and gender identity data before. We haven't effectively collected functional disability data before. And it may just seem like a new thing, but this is the piece that will continue to be vital. We'll learn from that in all future pandemics and all future emergencies. This is the piece that will allow us to know who are the people with the disabilities in the community. What's their race? What's their ethnicity? Where do they live? Where can they go for their medical care? Where can they get their vaccines? What are the barriers that are in the way? And so if there's a way to just include that piece as part of technical assistance, I just think it's absolutely vital and wanted to raise that.
Thank you, Sylvia. Well said. Well said. Esther, let's go to you, and then I think we'll have time for Diana.
Thank you. My name is Esther Bejarano. I'm with Comité Cívico del Valle, community-based organization in Antioch County. I do want to say that we had our first mass vaccination doses for farm workers, so we were very excited. We're partnered with the county, and so we were there. We actually registered over 800 farm workers. Here are the staff. I just wanted more clarity. I know that, and everyone who was an employer from any ag sector was, registered, wanted to register. And so I think that's very important, for our next vaccination distribution. I feel that, if they're working in the office, they don't have any contact with, so I feel that we need clarity. I did see a lot of people who could have waited. We did have a group of farm workers who did not have a letter or their check stuff because they worked in the field all day. They arrived at 4 p.m. and they were said, no, you're not getting vaccinated because you don't have your letter of employment when you can see that you just got off the field. And then someone else drove up with a big, SUV with their family, and there were farmers, were ranchers, and these are the letters. And so they all got vaccinated. I just wanted to mention that. I think it's important for those other communities that are going to be receiving doses as we continue moving forward with our local hospitals and counties. We do need more clarity on that, making sure that our essential workers and those in the front lines get vaccinated.
Thank you, Esther. It's always good to hear exactly what's happening on the ground from you and others. Erica, anything you want to add to Esther's comment?
I just want to kind of actually, even back to Sylvia's comments, just want to echo and agree that, I think one of the most challenging, so many things about this pandemic have been challenging, but I think our data issues are one of the biggest. And I think it's fundamental infrastructure, right? I mean, many people, even if they're collecting the data, they're doing it on pen and paper or, so I think, and in a state this large with 3 million people and 58 counties and however many providers we have, we have a lot of work to do to build up our infrastructure, our health infrastructure, and our data and health infrastructure. But absolutely agree with you that, we're really looking into investing into that in the future. And I hope collectively we all kind of think about that across the board, that we really need to have that investment in our health and data infrastructure and figure out how to centralize it. So I actually thank you for that comment and just want to acknowledge it's been a challenge, but really important and close to our hearts and a huge lesson learned from this pandemic. Thanks.
Good, thank you. Okay, Diana, please.
Thank you all so much. Diana Tellefson Torres with the United Farm Workers Foundation. My comment is along the lines of what you were talking about, Dr. Pan and Esther's comments. Just as we're now within phase 1B tier 1, where we're vaccinating farm workers, the UFW Foundation has been helping farm workers register through our call center. but we immediately flagged the fact that the My Turn site only utilizes food and agriculture in the aggregate as one criteria. And so I just want to emphasize the fact that farm workers should be its own criteria. We know that farm workers are not just in one location, they're moving from county to county, they're migrant, often uninsured, undocumented. It's a very vulnerable population. So as soon as possible, if we could separate out those categories, food and agriculture is such a huge category, which includes grocery workers and others. And so if we truly want to track whether we're reaching the most vulnerable, which we believe farm workers are in that category, then we really need to emphasize that in the data that's being collected on the ground. We still are, those of us who are working with others on vaccination events are tracking our own data about how many farm workers are getting vaccinated, but the state has yet to be able to provide that data. So I want to emphasize the very, very critical importance of doing that and being able to track that. So when we go back, food and agriculture as its own category isn't going to necessarily mean that farm workers are getting vaccinated.
Thank you. Erica?
Oh, I'll just start, and then I think Marta may be able to speak more to how it's working with teachers. And I think there's a lot of thought going in, sort of collectively in partnership on some of these issues, and how do we develop kind of ways to have like a pop-up, a portal for pop-up clinics for specific populations and maybe unique codes, but then working with navigators because, back to our collective points, we want the data, but we know sometimes the data and technology does not match the group we're trying to reach, and we need to have that appropriate intermediary and often a community-based, on-the-ground, trusted partner. So I think there's a lot of work, and over time we'll continue to be able to share a lot of that. But I think, and Marta, I think you're more on top, up to speed on this than I, but the teacher codes and how that's working, I think are a good model for how we're going to think about other groups.
Yeah, I'll admit that the teachers are probably one of the easier groups. It's going to be a little bit more nuanced and complicated as we deal with other groups. But how it has been working with the teachers is the school districts themselves are very aware of who's teaching in person and who's teaching remotely. And so they're able to kind of sort by occupational risk. And so by identifying those who actually have occupational risk and quantifying that and being able to share information with the state, and so that we can give individualized codes to those school districts that actually have that information. And then those can be distributed to the individuals. And so there can be a registration process to get them vaccinated. We don't have enough vaccine to actually vaccinate all those teachers. So it's small bits at a time, but it's trying to get them through this kind of narrow pipe of vaccine that we have. So that's how it's worked. It's going to be a little bit harder with communities that don't have such a defined structure as you do with schools to school districts to boards of education, and that we can communicate in such an efficient way that we can with teachers. But there's still, those structures do exist. And so we do envision for all sorts of different communities to be able to work with what we call group leaders, it's just the technology term, to be able to identify target populations, release codes, individualized codes. These are not codes that get put up on Twitter and that everybody can use, but individualized codes that are one-time use only to group leaders. And that those group leaders could be affiliated with employment. They could be affiliated, maybe it's a regional center that serves people with disabilities. It could be a community-based organization that serves people in a disadvantaged community. So there could be a bunch of different targets that we could partner with and be able to release just the single-use codes that allows them to either get into closed clinics that are targeted only for that population, or to be able to kind of get to the front of the line in open clinics. So both of those are strategies that we're contemplating to reach these various populations. But I want to be the first to admit that teachers are a little bit easier because of the structure on top of the teacher organization. And it's going to be it's going to take a little bit more effort and partnership to reach some of the other populations.
Great, thank you, Diana.
Initially separate out ag from food, agricultural workers from, even that would be helpful.
Right. Good suggestion. Okay, we need to move on to our last agenda topic, and I'm going to turn the agenda back to Nadine to introduce our next speaker.
Thank you, Bobby. And I am really pleased to introduce Dave Smith from Cal Volunteers to share about an exciting new tool through My Turn called My Turn Volunteer that we hope is going to support and supplement the work that many of our clinics and providers are doing.
Thank you, Dr. Burke-Harris, and thank you all for the opportunity to come and talk to you about the next part of the My Turn suite, which is My Turn Volunteer, which as of right now is now live at myturnvolunteer.ca.gov. And I'm going to walk you through a little bit of what My Turn does, both from the perspective of a volunteer director, which is somebody who's running a clinic on the ground who needs volunteers, and then also from the perspective of the volunteer side, which is both medical and general support volunteers. We are dependent on My Turn Clinic, which means that basically if a clinic is in My Turn Clinic and is posting opportunities for people to sign up for, individual My Turn appointments, they also can turn us on and be able to say, we need X number of volunteers to help meet the needs of our particular event. So the next slide shows a little bit of the path around the volunteer director, which is a clinic director helps establish a volunteer director, either someone on their staff or with an external partner organization that says, you're now going to help manage our volunteers. They go in and they log into My Turn Volunteer and they're able to create shifts. They're able to create these shifts based off of any number of, based off of specific times as well as specific roles. So that they can then recruit both medical volunteers as well as general volunteers. On the medical side, there's opportunities for vaccinators, vaccine prep, or patient observers. On the general support side, there's opportunities for greeters as well as volunteer support or registration support. The volunteer director can then go in and actually verify and confirm their volunteers, and then the system automatically messages with them so that they make sure they have the details to be able to then know where to show up and when to show up and any other information that's needed for their particular clinic. If you go to the next slide, you'll see kind of what the dashboard looks like for a volunteer director when they log in. They're able to track and see how many volunteers they have as a whole. They can see them sort of signed up day by day. The bottom part of this shows sort of volunteer by type, both in terms of general support or medical. And then if a particular volunteer director is assigned to multiple sites, you can actually see, based off of one clinic, how many people have signed up and are tentative. Tentative meaning that either they haven't completed their training or background checks yet. And then you can go through and actually confirm them, and you can see how many are tentative, and then confirmed, and ultimately move them through the process of then being able to show up in person. The next slide shows a little bit about what it looks like on the back end when the volunteer director sets up the opportunities. And we have a full job aid as well as an opportunity to go deeper into this with volunteer directors. But you can see on a snapshot, what does it look like over the course of the month? How many jobs have you created? How many of those opportunities are still available? Which ones have people signed up for? It also gives you the ability, if you need to cancel an entire shift, you can do it in one place. Because if your clinic was, didn't get enough allocation to run that day, you can then just have one communication to your entire group of volunteers and allow them to know that you can, they can come back to the system and rebook. The next slide really starts to talk about it from the volunteer's perspective. So the volunteer director is certainly the one who is asking for the volunteers. They are identifying what the different opportunities are, and they're the ones managing the process that includes verifying and then managing those volunteers on site. From the perspective of a medical volunteer, if I'm interested in being engaged, I can go to myturnvolunteer.ca.gov. I can put in my zip code and I can see what opportunities exist around where I live or where I work. If I'm a medical, I can choose one of these three types: vaccinator, vaccine prep, or patient observer. I can say I can sign up for one shift or multiple shifts based off of my schedule. I can provide my contact information. If I'm a medical volunteer, it automatically looks up my medical license to ensure it's in good standing. And then if I complete the online training, which is driven by the training that's required on the CDPH website and the CDC website, I'm then able to have a quick path towards being confirmed, and then showing up and actually completing my shift. This next slide shows what it looks like from a non-medical volunteer or a general volunteer support, which is fairly similar. It's just the roles are slightly different. And so you can be registration or greeter or administrative support. And then you ultimately can go through the process to then identify, you go through the process, finish your online training, any other role requirements. Some sites require background checks, others have different different components of what is required to ultimately show up on site. And as long as that's completed, you move from tentative to confirmed and are able to actually show up on the site. I only have a couple more slides here that'll show you kind of the path through. And so the next path shows what our homepage looks like at myturnvolunteer.ca.gov. You can see from the homepage, you can fill out your information so that you can sign up and we can contact you even if you're not able to find a particular site today. You'll be able to find other ways to engage, and we'll roll out as new clinics roll out. We'll be able to update you on those. The next slide shows what happens when you are able to put in a zip code. One of our pilot partners is Kedron Community Health Center. It's actually where Josh Friday, our Chief Service Officer, is today. And it's where you're able to then say, okay, I'm a medical volunteer. I'm happy to do any of these: vaccinator, vaccine prep, or patient observer. You then click select, and it takes you to the next slide that shows you how you can select your individual shifts. You can pick it based off of, I can do an AM or PM, or that day I can do a full day. There's a drop down where you can say I can do certain days this week, next week, be able to identify those shifts, and you can sign up for one or multiple. The next slide shows what the information intake is, which includes your personal information. It's a little small on here, but first name, last name, date of birth, email. If you're medical, it asks for your license. It does ask if you've received your first or second vaccination shots. It also asks for the language, both your primary as well as other languages you speak. And then your ability to travel. Are you interested in traveling less than 10 or more than 50 miles, being able to make sure that we match more opportunities to you. And the next slide just goes back to the overall information. Again, myturnvolunteer.ca.gov is where you can find the website. And myturnvolunteer@californiavolunteers.ca.gov is our email if anyone has specific questions or wants to bring a clinic on board, so we can help find volunteers for you. Or if you are a volunteer organization that generates volunteers, we certainly can also provide you information to be able to share that with your membership so that we can make this a one-stop shop for volunteers and those needing volunteers to help vaccinate all 58.
Thank you so much, Dave. That is fantastic. We're very excited about My Turn Volunteer, and we're running low on time, so I'm going to roll up a couple of questions into one. I think that you answered them, but the question was, can My Turn Volunteer work with private clinics or tribal clinics or urban sites? Can any clinic that's on My Turn can any clinic access My Turn Volunteer, or any clinic that's on My Turn?
So any clinic that's in My Turn Clinic can access a My Turn Volunteer, and we can turn that on if it's private or public or some other partnerships if you're in My Turn Clinic. If you're not in My Turn Clinic, you can reach out to us and we can see what other support we can provide, but the whole system is interconnected in the back end. But California Volunteers does try to support in other ways, including community outreach and other ways that we can help support those that are trying to support the vaccination efforts.
And do volunteers have to be vaccinated, or if someone signs up to be a volunteer specifically, do they have an opportunity to get vaccinated?
So volunteers do not have to be vaccinated. We did just get clarity on the policy, which is that a volunteer that completes a shift of 4 hours or more is eligible to receive a vaccination as long as the clinic administrator provides that approval. And that is something that we'll be encouraging, we'll be able to ensure is known across the state, so that people who are helping to support the vaccination effort are able to receive their vaccinations as well after they've completed a shift.
Fantastic. Thank you so much, Dave. That's incredibly exciting. And so we're coming towards the end of the meeting. I want to thank everyone again for taking your time for an excellent meeting. We had the opportunity today to do a deeper dive into our vaccine equity plan, into the work of the third-party administrator in partnership with GovOps to make sure that that we have a simple and straightforward process for vaccine allocation. I want to acknowledge there are a number of questions that folks have asked in this meeting, and that folks have asked several times in past meetings that we are working to get information on. There's one thing that I wanted to flag or highlight, which is that there may be things that are suggested in this meeting. For example, Diana's excellent suggestion around pulling out the farm workers in terms of my turn. And one of the things that I wanted to flag for members of the CVAC is that there are times, so with your many suggestions, and we take the pages of your questions and suggestions, and in between meetings, we work with all of our departments trying to track down answers, and sometimes the answers reside between departments or require, bringing folks together to do this work. And oftentimes, for example, there may be a question that seems a little straightforward that the answer is more complicated. For example, Diana, I was just thinking about what you were saying about if we want to track data for farm workers being vaccinated, we should change the category in my turn. It turns out the way that we track whether or not someone is vaccinated is not through my turn, but actually through care. And that they're all the complicated systems. My turn tracks the vaccine appointment scheduled, but you can imagine that it doesn't validate that appointment was completed. And the question of whether or not what we're trying to track is whether the appointment is completed or whether the appointment was scheduled are two different questions that require different teams to coordinate and understand how to best answer the question. And I say that to say that I want to recognize that there are some questions that have been asked several times. For example, verification, how are folks, can we give clear guidance on how folks should verify or, whether or not they're eligible, and verification for different levels of eligibility. For example, we know that for our childcare workers, just a letter from your employer is adequate, right? But for individuals with pre-existing health conditions, right, that question of how to do that verification, to what extent it's burdensome versus not, requires multiple conversations with multiple stakeholders to move that process forward. And so we don't always have an immediate answer at the next meeting, but I want to let folks know that the questions that you are raising, we are absolutely taking them back. And it may take some time, as we see with our announcement on equity yesterday. We talked about equity at our first meeting. That was in the week before Thanksgiving, right? But what I want to say to the members of this committee is that the points that you raise and the concerns and questions that you lift up, over and over and over again, although the answers may not be simple, our teams are absolutely taking this information forward. We're working very hard behind the scenes to be able to try to get answers for you. And I try to be, and Dr. Pon and all of us who are parts of the administration try to be as transparent as possible in terms of we're working on it. We don't have an answer yet. The answer may be a little bit more complicated than we hoped, but I want to highlight the extent to which this process and each of you as members of this body have enriched and improved California's process of vaccine allocation, distribution, and implementation. Your voice is important. Your voice is powerful. We're very grateful for the diverse chorus of voices that have influenced and shaped California's vaccine allocation and implementation process. And our commitment to you is to continue to take back these questions, these concerns, and lift them up. Try to do that difficult work of wading through to try to find the answers, and to come back to you with as many solutions as we can. It's not going to be everything, and I'm sure that, you know, there is some times where folks will feel disappointed or frustrated, but I really want to highlight how grateful I am for your guidance, your feedback, your input, particularly as we heard today. Hey, you guys may have created this policy, you think you solved the problem, but the way that it's working on the ground is not the way that that I think that you intended, right? This is what we want to hear from you. This is the work that we want to do together. We are incredibly grateful for your time and your partnership, and we look forward to continuing this process. And with that, it is 2 o'clock. Our next meeting is March 17th from 3 to 5 p.m. We look forward to seeing you then. Dr. Pon, is there any other final words that you want to share with our committee?
I know it's time and short. I just want to echo kind of everything that you just said, and just really, again, appreciate the partnership, appreciate that you are continuing to ask us the hard questions, and just know that sometimes they are hard questions and we are working hard to try to answer them or resolve them. You know, but it's so crucial that all of you do have this voice to us, and we really just thank you for your time and flexibility. Thanks again for the last minute change this week, and look forward to seeing you in a couple weeks.
All right. Thank you so much. Have a great weekend.
Thanks, everybody. Bye-bye.
Thank you.
And thank you.
Thank you.